everyone. I would like to thank first the ISPE for giving me this opportunity to present my case at such a big event. My case is a case of neonatal diabetes with skeletal dysplasia. So my patient is a 2-month-old male child, first by birth order, born out of non-consanguineous marriage, presented to us with respiratory distress and vomiting. On probing, we found out that there was increase in the frequency and also quantity of the urine, which was suggestive of polyuria. And on examination, we found out that the baby had severe dehydration. Along with that, he had acidotic breathing. Antenatal course was uneventful. He was a full-term normal delivery, cried immediately after birth weight of 2.5 kgs, exclusively breastfed, and age-appropriate developmental milestones were present. Family history was not significant. Initially, our differentials on the basis of this 2-month-old kid presenting with polyuria and severe dehydration were renal tubular acidosis, diabetic ketoacidosis, diabetes insipidus, and adrenal insufficiency. So we went further with the first year investigations, which were CBC, RFT, and LFTs were within normal limits. We did random blood sugar, which came out to be 480, which was quite high. And the blood gas analysis was suggestive of severe metabolic acidosis with high anion gap of 39.4. Urine ketones were also positive. So this was a clear-cut case of diabetic ketoacidosis. And as it was presented in a 2-month-old infant, it was a case of neonatal diabetes mellitus. As neonatal diabetes mellitus presenting below 6 months of age is often non-autoimmune and has a syndromic association. That is, there one or other gene is often mutated. So clinically, we tried to find out if there is any association that we can see. But so our provisional diagnosis was DKA and neonatal diabetes mellitus. So there was no history of any jaundice, no history suggestive of any skeletal abnormality, no history suggestive of any rash or diarrhea, no history suggestive of repeated infections, no history of hypotonia, no history of circus cycle or cyanosis, as is evident on various, as present with various genetic mutations associated with this condition, as seen in this table. Second year investigations we did. C-peptide was 0.39 nanogram per ml, which was very low. Then exocrine pancreatic functions were checked, which were normal. And USG abdomen was done to look for the pancreatic tissue. So normal pancreatic tissue was found out. This baby was managed. The acute condition was managed with IV insulin. And once he was stabilized, he was started on subacute insulin. Basal bolus therapy with injection Lispro and injection Glargine was started. Further course for this baby was at 7 months of age, he presented with the refusal to feed, vomiting, and respiratory distress in acute decompensation, and the acute condition was managed. At 3 years of age, he had presented with hypoglycemic convulsions requiring admission. At 5 years of age, this patient presented with jaundice without any other signs of acute liver failure. So viral markers were sent, which were negative, and AST and ALT, that is liver enzymes, were quite high. So it was a case of non-infective acute hepatitis. This patient was supportive treatment was given. The patient was recovered, and there was no recurrence further. At 7 years of age, he again presented with vomiting and altered sensorium in DKA, and this event was condition was also managed in the hospital. At present, the child is 8 years and 2 months old. He is doing well on basal bolus insulin therapy, injection Novorapid and injection Lantus. Total daily dose is 1.53 unit per kg per day. He has a variable glycemic control with HbA1c between 8 and 9 gram per dl. Other issues with this kid is he has a short stature. Then there are various skeletal abnormalities and neurological abnormality in the form of mild learning disability. On examination or anthropometry, he has a significant short stature, as can be seen in the growth chart, and a growth failure as the weight is also low. On head-to-toe examination, this child has a poor oral hygiene with dental caries, low set ears, short stubby fingers, genuvarum, short stubby toes, and flat wide feet as seen in the pictures. Skeletal survey was done, which was suggestive of dysplastic changes, enlarged metaphysis, thinning of cortices, small and irregular carpal bones, and phalanges were dense and cone-shaped epiphyses were present. So in my case summary, my patient has neonatal diabetes, skeletal abnormalities, hepatic dysfunction, and growth failure. On the basis of this summary,
maybe we can just stop for a second. Yeah, we can ask for people to put up their diagnosis here before we disclose it. I think that will be an audience can put on the chat box. What do you think is the most likely diagnosis in this neonate who presented with severe DKA at around 3 months, did not have any abnormalities, now had multiple episodes of hepatic dysfunction and skeletal abnormalities. I think this is a giveaway case, so people can put up on chat just before we disclose the diagnosis. That will be quite interesting, maybe. Okay, so we are getting a few responses. Monogenic diabetes, Modi, which one? I think this is a very giveaway one. And now maybe you can put up that table, Dr. Karishma. That will give us an idea on that. Yeah.
So the table suggests various gene mutations and associated abnormalities along with neonatal diabetes mellitus. So my patient has skeletal dysplasia, which fits into WOLCOTT-RALLISON syndrome. Along with that, he has liver dysfunction, which also fits into WOLCOTT-RALLISON syndrome, and neonatal diabetes mellitus. So genetic workup was sent, and which was suggestive of homozygous mutation in eukaryotic translation initiation factor 2 alpha kinase, which confirms the diagnosis of WOLCOTT-RALLISON syndrome. Neonatal diabetes.
Santosh, I think, was the first point to answer. So I think this is a very important constellation of findings that you have found out in this perspective, especially. Now, the key message probably from this case, what do you think are the key issues before we go ahead in terms of discussion? The key finding that you would like to highlight here?
Yeah. So below 6 months of age, whenever infant presents with such a condition like polyuria and dehydration and high sugars, we should always think of some or other syndrome like genetic mutation cause. And we should first, so we should send genetic workup so as to see for the expected multisystem involvement in future, as in most of these cases below 6 months, they generally present just with the neonatal diabetes mellitus.
And the second big message probably which comes out here is that at the first presentation, there were no features of skeletal abnormality. So this was something which is very important, that even if you do not have any syndromic features, it is definitely recommended to go ahead with the targeted testing. And this is what you will talk about, how genetic testing is extremely important. So I think 3 messages before we go ahead in terms of discussion based upon this case. First of all, of course, was dehydration with polyuria, which you very nicely pointed out means mostly an endocrine cause. You are losing a lot of water through the urine. So it can either be glucose, which is diabetes, it could be sodium, which is basically adrenal abnormality, or it may be plain water in the form of DI. So these 3 have to be considered. The second, you already mentioned, less than 6 months, you have to think of neonatal. And third, features may emerge and evolve over time. So he did not have hepatic dysfunction, he did not have a skeletal abnormality, and they emerged over time. I think these will be the key messages. So now you can please go ahead with the discussion further.
Yes. Neonatal diabetes mellitus, it's a rare genetic disease, the incidence being 1 in 90,000 live births. Occurs mainly before 6 months and rarely between 6 months and 1 year. Whenever an infant presents with features of diabetes mellitus between 6 months and 1 year and not associated with any antibody positive status, then neonatal diabetes mellitus should be considered. It is either transient or permanent and requires insulin therapy. Classification is based on classification. It is classified into 3 types, that is transient, permanent, and syndromic. So most common being KCNJ11 and ABCC8 gene mutation, which can be either transient or permanent, and in syndromic, the most common being EIF2AK3 gene mutation, which was found in our patient. WOLCOTT-RALLISON syndrome. It is a rare autosomal recessive disease described in 1972 at the first time by WOLCOTT and RALLISON in 3 siblings which were presented with skeletal dysplasia. It is a neonatal or early onset non-autoimmune insulin requiring diabetes associated with skeletal dysplasia and growth retardation. Fewer than 100 cases have been described in literature, and high incidence in consanguineous marriages were found out. The more common being in Middle East, North Africa, Pakistan, and Turkey, as consanguineous marriages are more common in these regions. So there was one study published in Lancet in 2015. DeFranco et al. Has done this study, the effect of early comprehensive genomic testing on clinical care in neonatal diabetes. So they had enrolled like more than 1,000 cases of neonatal diabetes mellitus, and they did genomic testing in these patients. So more than 800 had some or other gene mutation associated, and out of that 76 had EIF2AK3 gene mutation, which was suggestive of WOLCOTT syndrome. And it was found that if it is present in the consanguinity has WOLCOTT has high incidence in consanguineous marriages, and in consanguineous marriages, the probability is 10 times higher than in non-consanguineous marriages.
And I think just to add one more point, if you can go back to the slide again, is that if you look at the entire number, around 82% of individuals who have a non-consanguineous family and 85% who have a consanguineous family, we are able to reach a genetic diagnosis. So this is definitely one condition in which there is a diverse etiology, clinical features may not be apparent, and over 85-90% you can get a diagnosis. So therefore, there is a most definite role of doing a genetic testing in that setting, because as you very nicely mentioned, it can predict in terms of outcome, it can provide us information about treatment and long-term complications. And that's why it's very, very important from that. And this is what probably will be discussed in the precision medicine part, because this is the ideal candidate for that. Please go ahead.
The SEEP study, they have emphasized on doing genomic testing earlier in the course of the disease, as most of the neonates, most of the patients will present with only symptoms of diabetes mellitus initially. So if a patient, so as the age advances, the genomic testing done in the advanced ages, they were found out that there were more cases which were presented with skeletal deformities and liver dysfunction. And initially there was only diabetes mellitus, as it is seen in the bar chart. As less than or equal to 3 months of age, 88% patients were having only diabetes mellitus at the time of presentation. However, when more than 48 months, the skeletal deformities and liver dysfunction are seen in more patients. Etiology being, there is a mutation in gene encoding EIF2AK3, which encodes the protein called PRK protein, which is a transmembrane protein located on endoplasmic reticulum, and it has a key role in unfolded protein response. So basically, it's a endoplasmic reticulum stress or stress condition in which there is a mutation in this gene, and there is accumulation of misfolded proteins, which leads to apoptosis of beta cells, and there is high level of expression of these genes on beta cells and osteoblasts. So explains the skeletal deformities associated with this condition. So coming to clinical features, diabetes. Diabetes is an obligate feature of WOLCOTT syndrome. The onset is before 6 months of age. It is permanent diabetes mellitus, not autoimmune and insulin dependent. Histology is suggestive of hypoplastic pancreas with necrosis. Langerhans cells are small in size, and beta cell defects are found out. Second being skeletal abnormalities. There are multiple epiphyseal metaphyseal dysplasia affecting the long bones, pelvis, and vertebrae. A skull is generally spared. Osteopenia is often present, and multiple and frequent fractures are seen in these patients. There is significant growth delay, which is present in almost all the patients. Then third being liver dysfunction. It presents as a recurrent acute episodes of hepatitis and liver failure. Patient presents with jaundice, hypoglycemia, even in severe cases may land up in coma, and triggered by intercurrent diseases such as URTI or and in older patients, chronic liver dysfunction is often found out. The neurological abnormalities are are of variable severity. There can be intellectual deficit or developmental delay present. Neuromotor deficit is often present, and microcephaly with abnormal gyral pattern can be seen, and epilepsy can be seen in many patients. Some other associations, which are the rare associations with this condition, are central hypothyroidism, and it was reported in about 6 out of 26 patients in the series of Osbeck et al. Neutropenia, it was found out in 8 out of 21 patients in the series of Osbeck et al. Often it is associated with recurring infections. Discoloration of teeth, skin abnormalities, and dysmorphic feces. These are some rare possibilities associated with this disease. Coming to management part, insulin being the permanent diabetes mellitus, insulin is the mainstay of treatment, and they require insulin for lifelong. Liver transplantation can be considered in the patients having multiple episodes of acute liver failure, and surgical intervention can be done for skeletal abnormalities. So our patient was presented with almost all these features to us, and he is right now on insulin therapy, and his liver functions are, he had only 1 episode of acute liver failure, and now his liver functions are fine. And for the skeletal abnormalities, we are taking the consultation from the orthopedic side. Prognosis. This condition has a very poor prognosis. Mean age of survival being 5.8 years. The longest surviving patient we could found out in literature in India and South Asia is 8-year, 2 months old female child. And generally, the patients succumb to the sepsis, neutropenia, and liver failure. The key message from my presentation is the dehydration with polyuria, we should always suspect diabetic ketoacidosis. Patients presenting with neonatal diabetes mellitus at less than 6 months and between 6 months to 1 year without antibody positive, genetic testing is warranted. Consanguinity, skeletal abnormality, and liver dysfunction, high suspicion of WOLCOTT-RALLISON syndrome should be there. Thank you.
I think that was a very excellent presentation, Dr. Karishma, and you covered the entirety of this aspect. Now, few things that we need to probably, before we take up the questions, are very clear that this is basically a sort of a situation which is endoplasmic reticulum stress situation. So because of that, there is a gradual damage of the beta cells which happen, and sometimes this evolution may be slow. So while we are really saying this as entirely a neonatal diabetes, many of us have experienced patients who have a milder presentation and who may present more with skeletal abnormalities, and then they have developed diabetes. So that is very important, and many of them may have a variable course in that perspective. So it's not necessary that all of them will have the same spectrum. It may be a lot of other things which will affect the genotype-phenotype interaction, and there may be a gradual progression now which goes in that perspective. So before we really go ahead into the specific questions and discussion on that, just a few key points I would say that do you think we should also be considering the condition in older children if there is skeletal dysplasia and hepatic dysfunction, and even if they did not have diabetes earlier? What is your take on that?
Yes, sir. It is a spectrum of conditions. So generally in older children, they might just present with skeletal dysplasia, and the diabetes part is not that evident at that age. So we should always consider, and I think we should go for a genetic testing for those patients.
I think that's very, very important. The key message would be that if the disease is very severe, if it is syndromic, if it is too soon, or if there's a strong family history, these are the 4 components when we have to think of genetic and precision diagnosis, because that can alter the treatment in that perspective. Now, the other issue that we have talked about, insulin, liver transplant, and orthopedic interventions. Do you think there can be any other possible intervention which can be done to preserve the beta cell function in this case? Or have you seen any particular trials or experimental studies on that regards?
Yes, so experimental studies are going on. There is GLP-1A agonist can be used to preserve the beta cells which are functioning normally, and to reduce the endoplasmic reticulum stress is being done. and some studies have mentioned that there is some success. So
I think that few messages which are coming out from your case, besides the usual 3 big points that you mentioned. One is, of course, that often when we read about this, we often consider that this may be a very adverse prognosis and patients will not be surviving well. I think everybody of us have some patients who are surviving. Dr. Santosh has also mentioned about a case who is 12 years old now and doing well. I also have a couple of patients. So I think although the reported age is around 8 years, there will be milder cases which are there, which are looming around and roaming around, and their survival is more. So it's not entirely that you will have a very bad prognosis in all these cases and it may progress from there. We'll take some questions now, and so I'll encourage all the participants who have particular queries to put up their questions, and we'll see if there are any specific questions till now on that regards. Okay, there is a question. Yes, so we have a question from Dr. Varsha regarding any other MODI associated with skeletal dysplasia and without hepatic dysfunction. Dr. Karishma. So the most important association of skeletal abnormalities with regards to monogenic diabetes is, of course, WOLCOTT. There are a few overlapping situations in which can happen, but if you talk about a pathognomic triad of diabetes with hepatic dysfunction and skeletal dysplasia, we would say WOLCOTT is the clear-cut situation that we have to look at in that perspective, and that genetic analysis would really help on that in that perspective. There is so I'll maybe want to have some inputs from people who have managed the condition and how the course has been. Dr. Santosh can maybe chip in as to how his experience has been in that regard, sir. Dr. Aniket is asking a question about, is malabsorption associated with condition, Dr. Karishma?
No, sir. Generally, the exocrine pancreatic function is preserved. So malabsorption is generally not seen, and the studies that we have gone through, we didn't find that.
So actually, Dr. Aniket, this is a very, very specific group of conditions in which there is an issue of endoplasmic reticulum stress, as Dr. Karishma has nicely said, similar to something like Wolfram syndrome also. And because of this endoplasmic reticulum stress, there is a gradual destruction of beta cells. So they in a way behave more like a exclusive beta cell failure with no association of other aspects of exocrine pancreas in that perspective. So this is there. Now, there is a question. So Dr. Radha has mentioned that this, Dr. Radha from MDRF, the Madras Diabetes Research Foundation, has mentioned that they have a group of patients of this condition, and they also offer free genetic testing for neonatal diabetes in that regards. And of course, the spectrum would change with regards to the type of mutation, as well as, of course, the environmental factor in that regards. So Dr. Santosh has mentioned that the case that he's managing has severe hip dysplasia and hip pain, and he has got severe short stature, -6 standard deviation score, diagnosed at 12. So this is something which is very important to understand, that many of these conditions whom we consider to be very severe, very early onset diabetes may actually have a variable phenotype which may express over time, and this process can proceed from that perspective. Dr. Shala, any inputs from your side? About the overall condition and the neonatal diabetes and...
Dr. Anurag, Dr. Radha has joined.
Okay, very good.
Yeah, because she has more experience. She
Sure,
could,
sure.
yeah,
share. Good evening. Thank you. Thank you. Thank you. Yes,
welcome,
thank
Dr.
you.
Good evening.
Karishma, you can close your presentation. We have finished, right?
So we would really love to have your experience with regards to the overall numbers of neonatal diabetes, because we know a lot of genetic testing has been done at one of the leading centers. And what is the experience with the this condition in particular, ma'am?
Yes, we have about 187 neonatal diabetes cases which have been tested for at least 2 genes. say 3 genes, the potassium channel as well as insulin. And of course, now I'm trying to increase the repertoire, because we have only the, we don't have a next gen, but then we have a tie-up and all that. What we have is, we have a lot of KCNJ11 and ABCC8 mutation, and also insulin mutation. So most of the cases of KCNJ11, say about 80% of them, we are able to transfer them to sulfonylurea, but that is absolutely dependent on the way, the nature and the position of the mutation. So for that, what we do is we go through a number of tests, including functional genomics. So to find out whether this variant or this mutation is really causing a defect in the protein, whether it is not getting moving to the nucleus properly, and how it is transactivating, how it is expressing the other genes, etc. So putting all of them together, and also the current ACMG guidelines. So the current ACMG guidelines for any genomic variant has become extremely diverse, and about 28 categories of conditions we have to see. And more than the 28, what happens is each 28 conditions have a layer of like the strong, very strong, and all that. So I'm putting in all of them together and offering that kind of an experience here. So I'm able to say whether it is benign or pathogenic or non-pathogenic or variant of unknown significance. And it is only based on that, actually, we are able to see a follow-up. I have followed up patients for more than 5 years with the NDM. And then I'm clearly able to see that some of them have a very good response to sulfonylurea. And once they have a good response to sulfonylurea, they don't fail on sulfonylurea. They continue to have a very good glycemic control. So that is something, not a single case has shown a failure of sulfonylurea. If it is, let's say, the 80% that responds, the other 20% do not respond, and that is purely based on genetics. So we also have got syndromes like the WRS, WFS, and all that. So WOLCOTT RALLISON, I have seen about 6, and of which one of them died of sepsis. The others are all, 5 years, 6 years, like that. And they have clear-cut severe WOLCOTT RALLISON mutation with the skeletal dysplasia. So regarding the CHI, we do have about 150 cases where we have seen about 50% of mutations, and we have seen unresponsive and responsive to diazoxide. We have seen a lot of ABCC8 mutation there. So we are doing a number of tests, and I'll be very happy to collaborate with all of you and do the tests free, and we can all have exchange of ideas and knowledge.
So I think that's really interesting, Dr. Radha, in that perspective. So just maybe because we're going to just close the session now, I think the most important development which has happened in the field of, I would not only say neonatal diabetes, the entire diabetes in the last couple of decades has been the genetic diagnosis, which is being more available, and especially for the neonatal diabetes. We saw that study how 85% had a specific genetic diagnosis which was achieved. So now it's absolutely essential for all of us to get the test done if it's less than 6 months, 6 to 12 months with a negative antibodies. And of course, if you have a later onset with a syndromic presentation with a segregating feature and a family history, we can do. And now we have got the opportunity which is available from Dr. Radha's side